Hi, this is Professor Straker, and this session is on the FICA module of spiritual assessment. The major goals of this session, at least at the end, is you should be able to distinguish religion from religion or religiosity from spirituality, and you should be able to recall or explain or describe the FICA assessment tool, which we will be talking about in a few moments. So I'd like to start out with a definition of spirituality. Spirituality is the aspect of humanity that refers to the way individuals seek and express meaning and purpose, and the way they experience their connectedness to the moment, to self, to others, to nature, and to the significant or the sacred. So it's a broad definition. One way to look at it is spirituality is a way that people seek a meaning to life and have a connectedness to something beyond ourselves. And that something could be other people, other entities, it could be to the divine. Religiosity is where one is part of a denomination or a tradition, and within that tradition there are specific beliefs, rituals, behaviors that prescribe how the spirituality or how that religion is done, and people prescribe to that. Religiosity is a form of spirituality. People can be spiritual and not be religious. In other words, people can be spiritual and not be tied to a specific denomination or religion. Now, the Pew Center for Research every about 10 years or so does a religious landscape survey of the United States, and they survey about 35,000 people as a representative sample. And I thought this data kind of helps separate a little of the religious versus spirituality. When they ask people if they experience a deep sense of spiritual peace and well-being at least once a week, 65% of the people who are religiously affiliated, connected to a denomination, identified having this experience. 40% of the people who were unaffiliated also identified having this experience. When they asked people if they experience a deep sense of wonder about the universe at least once a week, 45% of the religiously affiliated did experience this, whereas 47% of the unaffiliated experienced this. The unaffiliated are those who do not, like I said before, not attached to a specific denomination. They might, for instance, believe in God, but not any specific, prescribe to any specific denomination. They might be agnostic. In other words, not disbelievers, but not fully believers. And they might also be atheists. These all can kind of fit within that realm. Spirituality is the umbrella, and religion is one of the things that fits under the umbrella. When we just look from that survey and we look across at the landscape, almost 90% of American residents believe in God. Almost 80% of them identify with a specific denomination. And over half of the folks who live in the United States pray daily. Now, there are some studies that have shown associations between either religion and or spirituality and different aspects of health. So there are some that show better outcomes. Matter of fact, I've read a double-blind study that for people who were undergoing surgery, and the people who were undergoing surgery didn't know this, and the people who were a distance away were given names and asked to pray for people. And the people that they prayed for, who didn't know they were being prayed for, and who these people did not know, when they did the analysis, it was statistically significant that those who were prayed for had better health outcomes. They recovered from surgery quicker, they left the hospitals quicker, they were less complications. These are other areas in which people have associations of spirituality with their health. For folks in the United States, religion plays an important role in their daily lives, and actually 61% of folks say that it's the most important influence in their daily lives. When they asked hospitalized patients, 94% of them believe that spiritual health is as important as physical health, and 79% believe that spiritual faith can help people with disease. Now, whether that means it's going to cure them or is helping them cope with it, either way, there are probably other ways that folks believe that it plays a role. So this is to say that this is what our patients are thinking, and we're going to be trained to be looking at one thing, but we need to recognize that our patients have more parts to their lives than what we talk to them about in terms of medicine and healthcare. In 1999, JCAHO, which is the Joint Commission on the Accreditation of Healthcare Organizations, they accredited the hospitals in the United States, set up as one of their accreditation process requirements that hospitals perform spiritual assessments on every patient, and they should identify at the minimum the patient's denomination, their beliefs, and their spiritual practices, and that the hospitals should make patients have access to pastoral services. Now let me talk to you about pastoral services for a moment. If you're in a hospital, and at least in most hospitals, and you call the chaplain has been trained, used a lot of times in a specific denomination, but they have been trained because they are chaplains in a hospital to be able to service people across denominations. And they have contacts with folks in other denominations. So let's say the person is the chaplain is a Methodist chaplain, and the person wants to be Catholic, not wants to, but they're Catholic and they like to have the Catholic sacrament. No, that pastor may not be able to do the exact same thing, but they can contact a Catholic priest, for instance, and make the connections for them to come in and receive the sacrament, or have someone else authorized within the Catholic Church. Or they can, if it's acceptable to the patient, they might be able to administer it through their denomination, but maybe not the exact same way the Catholics do. So that's to know. I want you to know that pastoral services and chaplain services in a hospital are not limited to one specific denomination. When we think about the role of medical practice and its relation to spirituality, our job is to basically understand the meaning of spirituality in our patients' lives. Because as patients come to us, they are diseased. They are not comfortable. They're stressed via their healthcare problem, or their medical problem. So they have a dis-ease. And if they're thinking that spirituality is the most important influence in their life, then that usually ends up causing some level of spiritual distress, or maybe there's a level of spiritual comfort that will help them through this process. So our job is to understand that role, and then to help identify if there's distress, and provide ways and resources that they can address that. So the spiritual assessment is a way to do that. It's a process of gathering that information, figuring out people's values and their beliefs and what they need, and as we kind of help them move forward in their care. The assessment has things like questions about their religion, about their spiritual beliefs, and who they might need in this process to help them deal with their spiritual side. So when do we perform a spiritual assessment? Clearly, as I told you from JCAHO, anybody coming into the hospital, anybody getting worked up as a hospitalized patient should have a spiritual assessment. When someone's coming into the practice and they're getting their full complete H&P, that's a place to do a spiritual assessment, just as you're finding out all the other things that they had in their past and the things that are going on in their lives. When you talk with people about their advance directives, when do they want resuscitation and those type of things, discussions around end-of-life care or long-term care. Those are places that a spiritual assessment should be performed. Now we're going to get into the spiritual assessment tool. Now, there are multiple tools. There are several tools. And FICA, which is the one we're going to talk about, was developed by Dr. Christina Pacholski. Dr. Pacholski is an internist. She does geriatric and palliative care right here at GW at the MFA. She's the director of GWISH, which is the George Washington Institute of Spirituality and Health. She developed this tool. And the tool can be used for anyone who's religious or anybody who's spiritual. It's not limited to a specific religion. And the tool is fairly simple. It deals with a mnemonic. The mnemonic is FICA, FICA. F for faith, I for importance or influence, C for community, and A for address. So we'll talk about each individual part. So F are questions that get at one's faith or belief or meaning. And I do want to say that you have an article to read and it goes into more depth. So I'm just going to touch on these. So these are some of the questions. Do you consider yourself spiritual or religious? And if so, what spiritual beliefs help you to cope with your stress? Not just your disease, but with stress. And if you do, and as you talk about though, what are those spiritual beliefs? And ultimately, and this is for everybody, whether they claim they're spiritual or not, what gives your life meaning? What's important to you in your life? And so that's a very important question. I is for importance or influence. So what importance does faith or belief have in your life? And on a scale of 1 to 5, how do you rate that? Excuse me, not 1 to 5, 0 to 5. How do you rate that? So 0 is none. Obviously, 5 is the most. You know, what beliefs influenced how you handle stress? We talked a little about that in the faith part. And what role do you think your beliefs play in your healthcare decision making? That's important. Sometimes we want patients to make decisions, or we're kind of, to make decisions very quickly. And understanding what role faith might have in this process, because sometimes the patient will tell you directly, I need to pray on it, I need to talk to my minister or my imam about this, and they need more time. But your job is to kind of understand that beforehand. So this will help you down the road and help the patient. C is for community. Are you part of a spiritual or religious community? One can say that they're part of a specific denomination and not part of a community. Maybe they don't go to church, a specific church, so they don't have a specific community, even though they prescribe to a specific religion. Is this of support to you? Is there a group of people you really love or who are important to you? So let's say one is part of a specific, and I'm going to use church, a specific church. Let's say there are 1,000 people in the church. But within that, there's a small group of people that they're more associated with. Maybe they've been active in certain projects together or whatever, and that group is really important to them. So that is part of their community. Maybe it's their family, and within their family, there's a smaller spiritual area or group of people that are very important to them in that process. A is for address and care. The other part of A is action. I'll get to that on the next slide. How would you like us as your providers to use this information as we care for you? Is there anyone or any persons who you like to speak with about this? So for many people, they might say, yes, I'd like to speak to my rabbi, or I'd like to speak to my minister. I'd like to have my prayer group. I'd like to talk with my prayer group. That might be important. Maybe now that you have this information, you'd allow me to have certain things that. The other part of A is action or address. And this is the part that is, what are the parts of action that can happen while they're in this the medical care system that will help the patient in their period of spiritual distress. One is we can easily refer them to the chaplain or to pastoral services or even to their own spiritual leader. Some of these other things are things that we might help facilitate. Doesn't mean that we will necessarily be the ones to do. We can facilitate maybe a place for them to have place or time for specific rituals. Patient might say, hey, I'd like to be able to play some music, and those type of things. It's important to know these. Like, let's say, for instance, the patient is of a religion where there are a group of people that will come in and they'll chant, and they won't even be chanting in English. And you have another roommate of this patient who has a different religion, and that might be kind of disturbing for us. So it's important to know this and then see how we can facilitate it so everybody can so we can be concerned about the well-being of all the patients that are involved in the process. What do we do with this information when we get it? Now that we've taken this assessment, what do we do with this information? Well, one is we put it in a chart. And the obvious part of the chart to put it in is social history. Another spot is the HPI, and that is specifically if it's related to the patient's main reason for being in the hospital or coming in for this visit. So it could be charted simply as Mrs. Jones is active member of the Methodist Church, or maybe even their specific church, the First National Methodist Church, and is also a part of a women's prayer group, and she would like her minister and her prayer group to be contacted and allowed to pray with her during this visit. Another place is under the treatment plan or the care plan, where you can put contact Mrs. Jones's minister, and put the name of the minister in the church, or contact pastoral services so they can contact the minister or whatever else. And by the way, when you tell the patient you're going to do something, you need to do it. So if you tell them that you're going to contact their minister, then you need to do that. If you decide that you run into like a family member, and the family member says they'll do it, and then under the stress everything's going on, they don't do it, it will look like you didn't follow through on what you said. So if you say, well, I'll talk to your child about this, or I'll talk to your family about it, or I'll talk to the chaplain people about it, that's what you need to do. Okay. Know that many hospitals have a spiritual care section of the electronic medical record or the chart. And just like those chaplains look at the medical record to kind of know what's going on for the patient, you should look at that to know what's going on for them in their spiritual side. So the goals of spiritual assessment are for us to understand and identify the patient's spiritual needs, and then to help be able to coordinate resources for them during our interactions with them as a clinician. Note that the spiritual assessment can be the intervention, that the patient needs the assessment as their spiritual intervention. That in itself can happen. Just like the medical interview itself can sometimes be therapeutic many times. There are effects, positive effects of the spiritual assessments. Studies have shown that just taking the spiritual assessment improves the patient's ability to cope with illness, and it improves the positive affect of the patient-clinician relationship. A lot of times patients they're diseased, they're uncomfortable, they think we're only going to deal with the medical part, and so they have to figure out in their own quietness how to deal with their spiritual aspect. Having the ability to just bring it out in the open, that you bring it forward, and that it's something that you'll allow, or there's a space that will allow for it to be addressed, really is helpful with the patient, and it's shown to improve compliance and basically save you time in the long run. So this is something that I learned, and I think we should all think about. We cure sometimes, We relieve often, but we comfort always. Thank you.